Assalamu alaikum. The clinical consultation day. First scenario, Mr. Roni, 32 years old. He's presenting with cough. Preclinical vitals are temperature normal, 37.5, heart rate 75, respiratory rate 15, saturation 95 on room air. He has been referred by GP as his cough didn't seem to respond to antibiotics which he gave him 2 weeks ago. Take the history, examine the patient, address his concerns. Yes, here you go. Ready?
Ready, Dr. Ayala?
Yes, I am.
Okay, here you go.
Hello.
Hello.
Hi, my name is Dr. Wayola. I'm one with doctors
Hi.
here today. Can I confirm you are Mr. Rooney, 32 years?
Yeah, I'm Mr. Ronnie. Yeah.
All
You can call
right.
me Ronnie. Yeah.
All right, Rooney, nice to meet you today. Okay. I understand from your note that you've been struggling, you've been coughing. Is that right?
Yeah. Sorry, doctor. Yeah, I've been coughing for the last 6 weeks. I've seen my GP. He thought it's a flu or something, so he gave me some antibiotics, which it's didn't seem to take this away.
Oh, I'm so sorry. Are you all right to continue, or you need me to give you some water?
No, I'm fine. Thank you.
You're
You
fine.
can.
All right. Okay. So I'm so sorry that you've been coughing for the past 6 weeks. That must have been difficult on you.
Yeah,
But
it's killing me. Yeah.
yeah, I'm so sorry. Could you tell me how it started? Did it started suddenly?
Um. It's difficult to tell, but it's been there. And the first, I thought it's could be a flare of my asthma, but I'm asthmatic. I've rarely used my inhalers because it
Mm.
comes as seasonal, and but still start to build up. Actually, since then, I had some fevers, but um, it never stops.
Okay, I'd say. And it's been getting worse since then.
Um, it's kind of stable, but it's there. It's not. The antibiotic didn't help, and even though when I tried the inhalers, it seems not to be working. To be honest.
Oh, I'd say. And it's the usual inhalers that you would normally use, isn't it?
No, it's just I use it whenever I do have asthma. I'm not regularly using them.
Okay, I'd say.
Yeah.
Okay. And do you produce phlegm with this cough? Any
Yeah,
phlegm?
yeah.
And what's the quantity? Is it much?
Um, um, Not too much, but there is a phlegm.
Okay.
And I've noted uh some yeah, it's not white in color. It's not the usual phlegm, you can tell.
Is it bloody?
Oh, thanks for asking this. It's once or twice I've noted that it is red, slightly pink in color, but the rest is just you can tell it's rusty. It's not the usual phlegm color. You can
Okay.
tell.
Is it foaming?
Um, no.
Any shortness of breath?
Um, Slightly, but it's not affecting anything.
Okay, so yeah, are you able to, can you tell me what distance, what were the things that you can do before that you can't do anymore? And this person said, does it come on exaction, I mean to say?
No, I'm walking fine. I walked from the car park to the clinic with no problem now.
Okay,
It's just slight building in the background, but I
okay,
don't feel that I'm that short of breath. You can
okay.
tell.
Does it breathing get worse when you lie down?
No.
Any leg swelling?
No.
Okay, and do you feel as if when you sleep at night, you wake up suddenly gasping for breath, anything like
No,
that?
no, no.
Any chest pain?
No.
Oh, okay, and are you aware of your heartbeat?
No.
Okay, I'd say. So have you any fever?
There is some fever which is I do believe it's been there for the last um 3 to 4 weeks, and I don't think it's been away after the antibiotic that the GB gave me.
Okay, I'd say. Is it, I can see that your temperature is a bit high. Is it very high fever? Have you ever measured your temperature at home?
No, but I do feel myself hot. You can tell.
Okay, I see. Any weight changes?
No,
Lumps and bumps in the body?
no,
Have you got any rash on your body?
no.
Okay, and have you noticed any change in your appetite?
Since everything started, yes, my appetite is low. I barely finish my meal, which is
Oh,
not my usual, but
oh, I'm
other than
so
this, no.
look, I'm sorry about that. What about your the asthma? Let's talk about this asthma. Okay, when were
Mhm.
you diagnosed of asthma exactly?
No, since childhood, and it's never been a problematic. I thought it could be. It's every now and then when it gets flared, if especially during season, but it's
Hmm.
well controlled. I never follow up for
Okay.
that. Yeah,
All
yeah.
right, good. And you have your inhalers that you use, right?
Yeah, it's just a risk in case if I get some cold, I usually tend to get some flares, but I thought it's the case, but for me it seems no, it's not the case. It's not asthma.
Okay, I see. And apart from this asthma, is there any other thing that you've been managed for?
No, no.
Any
I,
medication, apart any
it's
routine
just
medication?
antihistaminics for hay fever. That's it.
Okay, so you have a fever as well.
Yeah.
Okay. All right, that's it. And do you have you got any allergy?
No, no,
Okay. So this cough, let's talk about it. Is there anything that make it worse?
no.
Okay. So have you traveled recently, Mr. Rooney?
Oh yeah, I traveled. I've been in the last 3 months ago. I've been into quite different places.
Okay.
Um, I've been into India, I've been into Egypt, I've been into so many countries in the Middle East in a tour.
Okay, I see. And did you and that means I can see you've been throwing the word around. Okay, so do you have during this trip? Is anyone around you that cough? Any exposure to anyone that is coughing?
No, no,
Okay, is there anyone around you coughing right now?
no.
Okay, what activities did you do during this trip?
It's just normal going to the pub and having few.
Oh, all right, I'd say.
I did
Um,
some quite few binge drinks, but other than this, no, it's just enjoying touring around, eating. Yeah.
okay, all right. Okay, Mr. Rooney, do you smoke?
Very socially, minimally. I don't smoke, no. It's
You
like,
don't smoke.
yeah,
Okay,
on quite few occasions and none. I don't smoke, no.
okay. And what do you do for a job?
I'm a teacher.
Very church. Okay. Any exposure? Have you ever had any exposure to dogs, things like that? Anything like that in the past?
No,
No.
no.
Okay. Okay. So this just like a yes or no question. Do you have any headache?
Yes, there is some headache since everything started. Yeah. Uh, but it's response to paracetamol and stuff, yeah.
Okay. So with this headache, does it come with this cough or it's always been there before now?
No, it's when everything started 6 weeks
Everything
ago.
six
Yeah.
weeks ago. Okay. And it's everywhere in your head or just one
Oh
side of your
yeah,
head?
yeah, yeah, yeah.
It's everywhere. Okay. And paracetamol relieves it. Any
Yeah.
issue with your vision?
No,
Any neck pain?
no,
Any pins and needles in your hands?
no,
Any weakness in any part of your body?
no,
Any difficulty with swallowing?
no,
Okay. Do you have any weather preference?
no,
What about your tummy? Any tummy pain?
no,
What about your urine? Have you noticed any change in your urine?
no,
No foaming urine, no blood in your urine, right?
no,
What about your bowel? Any change in your bowel?
no.
Okay, all right. So how has this affected you, Mr. Rooney?
I called in sick quite a few times from my job last in the last 2 3 weeks. Um, this is pretty much because I feel that it could be. I'm a teacher, so
Mm-hmm. Okay. Okay, I'd say. Okay, have you got any family history of any medical condition?
no.
No. Okay, this is not to be too intrusive, Mr. Rooney. This is just a question that we ask people that have this kind of condition. Okay. Could you tell me about are you sexually active?
Yes,
Okay. Do you have a stable partner?
yeah,
Okay. And any risks of, unsafe sex and things like that?
yeah,
You said yes or no?
yes, yes.
Yes. Okay. And do you have multiple partners? Multiple sexual
No.
partner? It's just with your partner, right?
Yeah.
Okay. All right. Good. All right. Thank you for that. All right. So is it all right if I examine you?
Okay.
Okay. So first, I just want to look at you, look at the patient, look at the hand. Any
Mm,
problem in the hand? Any
No.
technique? Any skin changes?
No.
No. Okay. All right. So any cyanosis in the hand? Can I also want
No.
to check for pallor? Any pallor
No.
in the eyes?
No. No.
Any fluid enlargement? I look around.
No.
Okay. So I just want to examine your chest now. Okay. So I'll
Okay.
look at the chest. Any shortness? If the patient has shortness of breath at rest,
No.
chest expansion.
Fine.
Fine. Okay. The tactile femtors, percussion notes.
Percussion is fine, is normal.
Okay. What about the breath sound? Oh no, the trachea first. Any change in trachea?
No.
Okay. Auscultation, breath sound.
Breath sounds are normal. Vesicular.
No, and no
Harsh.
ash. Okay.
Harsh vesicular, yeah.
Okay. Any wheeze?
No.
No wheeze. Okay. All right. So I just want to check your tummy as well. Does any pain in the tummy?
No.
All right. So I just want to check for your neck stiffness. Okay. Do you have is there any neck stiffness?
No.
Any signs?
No.
Okay. So examination of the eyes quickly. Looking at the eyes. Any
It's fine. It's
It's
normal.
fine. Okay, the eyes is fine. No ophthalmoplegia, and also want to do fundoscopy as well.
Fundoscopy is normal.
Fundoscopy is normal. Okay, all right. Thank you for allowing me to examine you today, Mr. Rooney. Is there anything that worries you the most?
I don't know. I won't understand what's happening with me, to be honest.
Well, Mr. Rooney, looking at all that you've told me and all that's been going on with you, there's a couple of things that is actually going through my mind, okay? And I understand that you've been having cough for the past 2 weeks and you've tried some antibiotics from the GP, which is not helping, okay? And looking at it that you have an history of travel, okay, and they also fever and this headache that you are suspecting. I'm putting in mind that possibly there must be an ongoing infection, and bearing in mind that your recent travel. By the way, could I check how long ago did you travel to Egypt, India, and the lights? How long ago was that?
How long ago? It was a few
Yes,
months ago.
few months ago. Okay, so I'm suspecting that possibly there could be some infection like tuberculosis. It's just it's just a,
Oh.
it's just something that we need to investigate. Okay, and because you also told me that you have a background asthma, that though is not, it's just there, and you use your inhaler whenever you need it. I'm so thinking that there are also some other things that might be considered in your case, maybe some form of fungal infection, okay, that have wall off over time, what we call allergic bronchopulmonary aspergilloma is something I'm consider. Don't worry about the name, just a big name. It's like an fungal balls in the lungs. I'm also thinking of a possibility of some affectation of blood vessels in your lungs, what we call
But
vasculitis as well. So
yeah,
all
doctor,
these are possibility. So I
doctor,
would.
doctor. So just, I'm sorry, give me a room here. I think so. You've told me quite a few things. They seem to be serious. Is it serious, you think?
Well, at this point, we also want to make a diagnosis first by doing some investigations, okay? So when we make do the investigation, and we're able to arrive at a diagnosis, then we'll be able to discuss if it's something serious or not. But I think that because we've been coughing for a while, it's something that we need to take seriously and, investigate more deeply to look at what is exactly happening with you.
Okay, what? So am I going to be admitted or not? Or if not, should I be going to work or not?
Well, at this point, Mr. Rooney, because I'm thinking of something infectious, I want to do some basic investigation for you. First, look at what it is And then if we can able to rule out something that is infectious that can be dangerous to the community at large, then we can decide if it's okay to go to let you go or not. Okay, but I want to do the investigation while you are with us for now. Okay.
Okay. Okay. But
Yeah.
would I be going to work or no?
Okay. Well, by the way, could I just ask that does this cough get worse at work?
No.
No. Okay. Well, a possibility that you might be able to go to work is there, but first, like I said, let's be sure that it's not something infectious. By doing the investigation, once we are able to rule out those infectious side of the thing, then we can then take it up from there. But
Okay,
we'll advise you in the meantime, you wear your nose masks and while we investigate you further. Okay?
Okay. Time is up. Well done, Dr. Ayula. Let's hear the question now. Examiner question. Omar, yes, please.
So, doctor, please summarize this case for me
Okay.
and tell me what positive finding you have.
Okay, I just spoke to this 32-year-old gentleman who is presented with cough of 2 weeks duration, not responding to antibiotics. He has a background asthma, which he uses inhaler for. It's well-controlled asthma, and apart from, they also had this cough has been it has this cough which is produced of phlegm with occasional it has to with occasional brown sputum. Apart from this, patient doesn't have any other no chest pain. He has shortness of breath and no other findings on the history. He's also a smoker, and yeah, it's also a smoker. Examination findings, the positive findings is that is found in the chest. It has a ash breath sound in the chest, but no lymph node enlargement, that was noted, and the temperature from the examination was febrile from the examination from the data that was given. So putting all of this together, there are a couple of things that is going. There's a couple of differentials that can be entertained here. Patient has a significant travel history to high risk area in the last couple of months. So I'm thinking of a possibility of a pulmonary tuberculosis in this patient. Though there is pulmonary pressure in this patient, other things I want to consider will include the possibility of allergic bronchopulmonary aspergilloma in this patient. I also want to entertain the possibility of allergic bronchopulmonary aspergilloma in this patient. Then I entertain the possibility of some vasculitis in him, but I will expect, but because he has no rash, he has no joint pain or weakness, this would be put down in my differentials.
So your primary suspicion is the tuberculosis, you said?
I would put it, yes, I'll consider
Yes.
tuberculosis, yes, in this patient.
Does this patient, if you the first clinician to come in contact with him, do you consider managing him as an outpatient or as an inpatient?
For this gentleman, I want to manage him. I want to cancel him on the disease and then manage him as an inpatient until we're able to make the diagnosis, and then we can take it off from there. But I want to admit him.
Okay, so knowing that he's a teacher, would you advise him to go back to work before confirming or disconfirming the tuberculosis?
No, I would advise him to, because of the risks of contacting, because of the risks of exposure to school-age children, I would advise him not to. And that is why I want to keep him until we're able to make a diagnosis.
And for how long he should be
At least 2 weeks.
2 weeks. Okay.
2 weeks.
Okay. And what regimen you would start this patient on?
For this patient, after I've been able to make my diagnosis from sputum sputum and acidic bacilli, I want to start the patient on quadruple regimen, rifampicin, isoniazid, paracetamol, and ethambutol.
Okay.
For this patient for the first 2 months, and then continue on rifampicin, isoniazid for the next 4 months.
Okay. Thank you, Dr. Ayola.
Thank you.
Still less 40 seconds. I will ask
Oh,
you
I
some
thought it's
question.
time. I'm sorry. Yeah.
If you have
So
some question, you can ask. Yes, please.
yeah. We can at this sitting, how you would manage the patient in terms of investigation. You
Okay,
said that you want to admit the patient, but investigating this patient.
okay, investigation wise, first I want to do a chest X-ray. I want to do oxygen saturation in this patient, which is I can see that is 95%. Then I also want to do a chest X-ray, then sputum culture sensitivity and sputum microscopic culture and sensitivity. Then I also do acid bacilli. Sorry, in this patient.
Yeah.
Then I'll also consider possibility of gene experts as well. Then other blood tests will be done, full blood count, inflammatory markers, liver function tests, electrolyte creatinine in preparation for the patient for treatment in this patient. Then I also want to cancel on the need for HIV screening as well as hepatitis B and C because of the risks of co-infection in such patients. Then yeah, that's how I want to investigate this patient.
Thank you very much.
There's okay, yeah.
Anything you would like to consider in terms of management? Any teams you would like to involve?
Yes,
Yeah.
good.
Yes, this patient will be managed multidisciplinary, and I want to involve the infectious team.
Okay.
In this patient, then the specialist nurses will also be important. Then this case is a reportable case as well, so I want to report it to the infection departments.
Okay. Any other teams you would like to involve other than that?
Other than that, then I would want to involve the. Okay.
Don't worry. Thank you.
Yeah,
Do you think that this patient would need an admission to what kind of ward?
yes, patient will need admission to a negative pressure room. Yep. Yep.
Okay. Thank you very much, Dr. Ayola. You've done so well.
Thank you.
Yeah, perfect. Thank you, Dr. Omar. Dr. Ayula, you can comment now.
Dr. Ayola, you've done so well.
Based on the skills, you can see the skills in the chat box.
In terms of physical examination, I think it would be ideal to look for BCG scar. This is things, it's a reminder for myself and everyone, check if the patient does have. I know that it's not a routine vaccine in UK now, but if you are seeing it could be an immigrant patient, it is would worth examining the shoulder area for looking for the BCG scarf. Identifying the finding, you could have elaborated more on the patient job and who lives with him at home, in terms of any old people, any people on taking long-term steroid, any people who are immunocompromised, basically, because they need to be prioritized for the infectious control for the infection control team to be traced and started prophylactic treatment if possible. Your communication was very, very well, and your clinical judgment was very reasonable. And in fact, the fact that you brought in the allergic pulmonary aspergillosis into the differential was very reasonable. You've managed the patient concern very well. However, you weren't affirmative. The patient reminded you, or the surrogate reminded you, that he's a teacher, and in order to prepare for the concern that should I go to work, you should tell him, don't go to work, and it should be clear. Given the fact that this patient does have high risk feature of tuberculosis. You are suspecting tuberculosis. You shouldn't allow such an individual who deals with public. He's a teacher, banker, or doctors, or high risk jobs, police officer, or whatever. He's dealing with public. So we don't want to spread the infection. But apart from this, I don't have any other comment. I don't know if Dr. Bassem would like to add something that I've missed also
Yeah,
as well.
actually, she did perfect. I could give her full mark, but I will minus her only in the history, clinical communication, when she mentioned the finding to the examiner. She missed or she forgot to say about the night sweat and the loss of weight and appetite.
Yes, night sweats. I added it. I forgot. Thanks, Dr. Bassem.
Yeah, it's very important. Why you give her you give this diagnosis, Miss Dr. Ayula? Since you have loss of weight and loss of appetite, night sweats, this is your pathognomonic features of TB in such patient. Added to this, the blood tinged sputum, right? And of course, the history or travel history, along with maybe contact with sick patient. If you do so, you can get full mark easily. Yeah, putting differential of allergic bronchopulmonary aspergillosis, since the color of sputum little bit brownish, based on the past history of asthma, it also give you good mark the differential. But I prefer not to mention all this differential to the patient. Patient is
Yeah.
asking for one only, what I have. So you give him the most or the top of your differential. I think you have pulmonary tuberculosis, as you mentioned. It's one of the infectious disease that you have to be isolated from the people or public. That's why we advise you not to go to the work. We'll give you sick leave in order not to spread this infection. Based on your also travel history to India, which is endemic area for TB, along with the weight loss and appetite. This what I wanted you to mention to the patient, not to give him a lot of differential. He doesn't care what other differential, doctor. He is not examiner. So please minimize your differential to the patient. Give him the most top sensible differential. Even if you don't know, tell him I suspect many of the disease. I should run blood tests and some scans to be sure. Then I will sit with you. It's okay to mention that. But since you put the TB on the top of your differential, it's enough to mention the TB. No need to go through the others. If he will ask you, doctor, do you think I have a cancer? What do you think the answer, Doctor Ayula? Is it a cancer, doctor?
Okay, I would say that that's quite a good question that you've asked. At this point, I do not think that it is cancer, but because of the symptoms that you presented with, is something that we would want to do investigation to rule out.
Perfect. Still weight loss and loss of appetite, night sweat. It's sinister symptoms, and it could guide also you to
Or
a cancer.
or we can say, if you don't mind, Dr.
Smoker
Bassem,
as well. Yeah.
but we can say we will be doing imaging anyway for you, so some scans. So this would help us to identify if there is any cancerous activity. What do you think?
Yeah, I agree to say that.
Yeah.
And even you can put it in your differential to the examiner if he asks you what else, since he's having also weight loss and loss of appetite with the history of smoking. Yes, he's not heavy smoker. Maybe he's negative smoker. Okay, so I suspect a cancer, and I would like to roll out cancer. But on top of my differential would be TB. Yeah, the case is very straightforward. Nice case. The performance was perfect, Dr. Ayola. You're ready to the exam. The approach, what I like, you do, and you did properly from the analysis of the complaint till the end of the scenario. You follow the approach appropriately, and I think you didn't miss any of the questions. Okay. Vasculitis here, I don't think you can put it unless you have some joint, as you said, since no joint pain. So you can remove the vasculitis and put the cancer. Okay. Yeah, otherwise I don't have other comments.
I think I think chronic pulmonary embolism can go into this patient as well, bearing the travel history, though it's a distance travel thing, and there's no other thing that we could pick that could be a risk factor in this patient. But then, just thinking.
Yeah, okay, you can mention, but you have to have long trip or long time trip, swelling in the legs,
Yeah.
right?
Mm.
But it's okay. Yeah, what you mention is enough as a differential. But please don't forget always the serious thing. Here, TB is very serious one. The cancer as well, one of the serious differential I should and I would like to roll it out since he's having the sinister positive sinister symptoms. Okay.
Yeah.
You have any other comment or question? Dr. Omar, you want to add anything?
No. You've covered everything, Dr. Bassam.
Yes. Okay. I will post your scenario, Dr. Omar. Be ready. We will read the comment
Okay.
and we will start after a while. So your patient is, give me a while. Yes. Mr. Bassi, Nathaniel Bassi, 32 years old male, struggling with walking. So he has difficulty, walking difficulty. Okay, let's assume his name is Adam Smith. Something easy to pronounce. Okay, Dr. Ayula? Sorry, I mentioned the name.
It's okay.
Okay.
I do prefer difficult names because it's their
Yeah,
names here. This is very
I believe you can say Sayer
yeah.
better than the name she messaged me. Okay, or any.
No, yeah. Can you
Okay,
post
so
the scenario
yes,
a bit?
I am. John Smith, okay, John Smith, 32 years, struggling with walking. Be sure, Dr. Ayula, you ask about blood in the sputum or phlegm clearly. Okay, you ask this question. You ask, is it bloody or no? Okay, but be sure that you are asking fresh blood.
Okay.
And the pallor, of course, you have to examine and to ask about dizziness if you have any dizzy spells. Because you had 4 minutes, I think, after examination. I believe in the exam you will take examination steps. It will be longer than in the online session. But you have to do full examination of or full chest examination, inspection, palpation, percussion, auscultation. The also cardiac examination as well as the pulmonary hypertension signs. Okay. Okay, Dr. Omar, be ready. We'll try to. Anyone has comment quickly, he can comment. We can read the comments in the chat box. Okay, pulmonology, of course, you have to mention the pulmonary on top of your team. Chest doctor to the patient and pulmonology to the examiner. Infectious team, side room, of course. Isolation for how long, Dr. Ayula, as you said?
2 weeks.
Exactly. And the regimen for how long?
6 months in total.
Exactly. Don't forget to mention vitamin B6 or biodoxine.
Yep.
Okay, it's one of the medication should be given along with isoniazide. Okay. What else I wanted to be more complementary to this case? Yeah, the travel history also try to analyze it more. For how long did you have contact with sick patient who's coughing? Okay, India, I particularly, where did you eat? Did you stay? All this makes sense that you are knowing that, or the examiner should know that you are analyzing and you want to know is it risky travel for the TB, which is your top differential. Okay. So Amar, whenever you're ready, let's start.
Can I comment on this case?
Yes, please.
Right. I think that, yeah, so Dr. Ayola did very well. I think that she almost covered everything, and the history was very appropriate, and I think that she was very fluent as well. So I think that I don't see anything left in the history. The only thing I feel that regarding the fever could have been asked a little bit just to see the pattern, and as because the first differential was tuberculosis. So as you mentioned also, the night sweats and the timing of the fever, all these things. But otherwise, I think it was I mean, everything was perfect. The thing with in terms of the management, I think, because the patient in his concern mentioned about can he go to the office. So obviously, if you are going to keep the patient in, so you need to tell the patient that will involve the occupational health physician because, and that's something which most likely will be required because the patient will be off sick for few weeks, and I think that could be another appropriate
Mm.
involvement in terms of your team management. And regarding isolation, so isolation depends upon the type of tuberculosis. If the patient has a smear negative TB, in that case, after 2 weeks, the patient uh, can come out of the side room. But if it is a smear positive or a culture positive tuberculosis, in that you need to wait for two negative samples before the patient can leave the side room. So this is something which, so if the cultures come back positive, I mean, if the sputum shows positive AFP and also the cultures are positive, so just need to wait for a couple of cultures to come back negative before the patient can be taken out of the side room. So I think this is the only thing I wanted to add.
Yes, perfect, Dr. Hasham. So it's a notification, you mean, notifiable disease?
Yeah,
So,
it is. It is
yeah.
because if you're suspecting tuberculosis, obviously, because it's the diagnosis is still not confirmed, but obviously this is one of the thing because you see, Dr. Pasim, at time
Mhm.
even in our wards, if we are suspecting that someone may be having C. diff infection, even before the results, we transfer them to the side room. So this is the case with this. If you have a high suspicion that this could be pulmonary tuberculosis and it could be smear positive at the moment, you don't have the results. So it is better that you take the patient to the side room, do these investigation to confirm because you are going to treat only once you have a confirmation of the diagnosis. So at the moment, patient is in a stage where he needs to be investigated further. Once a diagnosis is confirmed, then you will need to involve the other people. It is a notifiable disease. Then you will need to involve the pulmonologist, the infectious disease team, and then all these. But before going for that, whenever there is a high clinical suspicion of tuberculosis or any infectious disease, in that case you just need to isolate the patient till the picture is more clear. And obviously because the patient will not be going to work, so that's something which need to be sorted as well.
Yes, exactly. I want to add also one comment, Dr. Ayula. Whenever the surrogate is repeating the question for you, means there is a trick. He
Mm.
asks you many times, will I go to my office? Will I go to my work? Mean there is something hidden here. Why he's repeating the question? Please revise your answer and be sure that there is something hidden here. So you have to change your answer. No, I'm not sure that you can go to your work since you are in contact with children. It's very risky to transfer this infection to them. Adding to this, if the examiner asks you, he might ask you, doctor, what else you want to do? If the infection control involves, what do you think is important here? As any notification or as any notifiable disease, what you should do?
Contact tracing.
Exactly. Yes. Yeah. Yeah. If you have any family member at your house or the workplace, they have same symptoms, please let them come to us. Possibly this with the communication scenarios more than the non-clinical consultation. But I want to just remind all. Okay.
Oh.
Okay. Well done, Dr. Ayula. Perfect. Really, it's perfect performance today. Let's start with Dr. Omar. Ready, Dr. Omar?
Yes.
Yes. Very good. Dr. Omar, you can start.
Yeah, can you hear me?
Yes, I can.
Yeah,
Yes,
okay.
now we can start. Yes, please.
Hi, Mr. John. I'm Omar. I'm one of the doctors here today. Can you please confirm your name and age, please?
I'm John Smith, 32, but you can call me John.
Hi, John. I do understand that you came to see me about some issue with your walking.
Oh, yes, doctor.
Yeah.
I've been struggling with my walking in the last 4 weeks.
4 weeks. Okay, so it's very, very, very recent. So is
Mm.
it both both of your legs or just one?
It's just my left leg.
Your left leg. And this has started 4 weeks ago
Yes.
and started all of a sudden?
Well, I can't say all of a sudden. I just noticed I woke up and I found that like I'm struggling with walking, and it's just been difficult since then.
Okay, since then till now, is it um progressing? Is it more worse or still is it the same?
I'll say it's the same, but I just find it uncomfortable.
Okay, and describe to me what do you mean by difficult to walk?
Oh, doctor, I feel like there's a pain just around my ankle.
A pain around your ankle. Okay. Is that so this pain withholds you from walking or is it some sort of weakness?
No, I don't think it's weakness. I think it's the
Okay.
pain. I don't want to walk on the leg, on the
Sorry
foot,
for
so I
that.
find it difficult.
Okay, so the pain is in your left ankle.
Yes.
Is there any other joints that it's also have the same pain?
Yes, my right ankle as well, but not as bad as the left ankle. And sometimes I feel the pain on my knee, my right knee.
You're not your right knee. Okay. So does it come all the time, those pains, or on certain occasions you've observed them?
They've all been there in the last 4 weeks.
So all have been so before the last 4 weeks, you were completely normal.
Yes, I'm fine, doctor. I was fine for the last
Do,
4 weeks.
do you mind if I asked you before the 4 weeks, how was your health back then? Is there anything that has happened you can after which the symptoms have started, for example?
No, no. The only
No.
thing I could say is I struggle from back pain as well. So
Okay.
yeah, and that has been there for about 2 years now, thereabout.
Oh,
Yeah, so that's the only thing I could say, in particular. But aside that, I'm well, doctor.
okay. So back pains for the last 2 years. Where is the pain exactly in your back?
Lower back.
Lower back. Okay. And have you tried to see doctors for that or
Yes, I've seen my GP, and my GP
Mhm.
think it's because of the work I do because I'm an accountant. I
Okay.
sit most times of the day, so he thinks it's because of the chair and things like that. So I've had some occupational health referral, which
Hmm.
has been quite helpful. But then, no, I still feel the pain.
Okay. So no imaging has been done for your back?
No, no,
No. Okay. And apart from this, how is your health in general? You do have any other medical problems? You see clinicians for
no,
it regularly? No.
no,
And you're not taking any medications?
no,
No. And no allergies?
no allergies, doctor.
Okay. So John, now back to the pains that you felt quite recent for 4 weeks. Can you describe the nature of the pain for me, please?
Oh, it started, like I said, I'm not, it's just there. I just noticed the pain that started, and it's always there, or at all
Always
times.
there. Okay.
Yes.
So you have tried you think that have you tried anything to make it better?
Yeah, I've tried some
Mm,
painkillers, just the one I use for my back,
okay,
so form
and
of ibuprofen, and it works. I feel
it
much
works.
better. Yeah.
So ibuprofen helped with the pain.
Yes, it does help.
Okay. And has anything you've noted that makes the pain worse?
I think when I rest, the pain it's worse than when I rest.
And toward the pain, is it worse by the beginning of the day and improves toward the end of the day? Do you think this is true?
I'm not quite. I can't say about that. I'm not quite sure.
Okay, so in the beginning of the day, when you wake up, is the pain there?
The pain is there when I wake up in the morning.
And you've mentioned that it gets better when you walk.
When I walk, yes, I feel better. Over
Okay.
time, it gets better.
Okay. Now, other than the pains that you've mentioned, do you have any changes in your hair?
No,
I Have you noticed any problems with your eyes, gritting? Drum.
No, not recent,
Minus.
but previously I've had some high cont issues. My eyes are turning red eyes, itchy eyes, gritty eyes. And I went to the hospital and yeah, I was given some eye
Okay.
drop and I feel better afterwards. That has happened about 2 times now.
Okay.
Hmm.
Okay. Okay. And apart from this, do you have any, what about your bowel motions or your bowel habits?
Good,
Are they normal?
good,
Okay.
no.
Okay. And your water works?
Good. Waterworks is good. I pee all right. There's
Mm-hmm.
not really any concern. Just that of recent, I started noticing that my urine is foaming. I don't know if that's quite important, but if I pee
Yeah.
all right, but just as the only thing I've noticed in my wee.
Have you had, okay, have you had any recent, so for that, is it during the last 4 weeks for the foamy urine you mentioned?
No, it's been there for more than 6 months. About 6 months
Okay.
now, yeah.
Okay. So right before that, have you had any recent diarrhea or any discharge from your front passage?
No, doctor.
No. Okay. And other than this, do you have any swelling in front of your neck
No,
with a preference?
no,
Dry mouth?
no,
Okay. Chest pains,
no,
awareness of heartbeat,
no,
um, any pains in your neck?
no.
Okay. Apart from this, do you know, you mentioned that you are an accountant. Is that affecting
Yes.
your job by any mean?
Yes, I've not been able to go to work in the last 3 weeks because of the pain in my
Okay.
ankle.
Okay, sorry for that. And is it because of the pain only?
Yes.
Okay. And on the and how things at home? Do you live do you live by yourself or with someone?
I'm alone.
Okay. And what about your accommodation? What type of accommodation you live in?
Shared apartment.
Apartment with a building that has stairs or escalator?
Yeah, it has stairs.
Stairs, and how you are managing to go to your home?
Oh, difficult. I've been most times up just in my room. So I've been making a lot of my stuff, ordering it online and delivery. Yeah, it's so difficult.
Yeah, I can imagine. I'm sorry that you're going through that. Do you smoke?
Yes, I do.
How many?
Oh, I smoke about 10 stick a day, and I've been smoking since I was 17.
Since you are 17. And what about drinking alcohol?
Occasionally, weekends.
Are you sexually active?
Oh, yes, doctor.
Okay. And do you have a stable partner?
Yes, I do.
Okay. Do you practice safe sex?
Yes, I do.
Okay. Thanks for answering my questions. I think, is it all right to go for the examination? But
Oh, sure.
beforehand, do you have any idea about what might be going on with you want to share with me?
Doctor, I'm not quite sure. I just
No.
think possibly maybe something I've maybe hurt myself in the legs and my ankle, and I'm not quite aware of. But I don't know.
You didn't had a fall recently, do
No
you?
fall, no fall,
No fall. And you didn't hit your ankle.
no.
Okay. So I'll start the examination.
Mm.
Would that be okay with you?
Oh, sure, doctor.
So I'd start by examining the gait. If is the patient able to walk?
He's able to walk, but with pain, antalgic
Uh,
gaits.
okay. And okay, that's enough. You can have a seat.
Mm.
And I will start examining the ankle. Is
Mm.
there any crepitus, any
Mm. No,
no, any skin changes around the ankle, any skin changes in both legs?
it's hyperemic. Are at the back of the ankle.
I'm sorry, I didn't hear.
Redness on the skin, hyperemic skin.
Redness. Okay.
Yes.
Is the joint swollen, hot?
No.
No. Redness behind the ankle. Okay.
Yes.
And is there any rashes on the shin of the tibia?
No.
No. And about I will examine the knee. I will do inspect and feel for the temperature change. Any swelling, any apparent swelling in the knee?
No.
Okay. And is there any laxation, subluxity in the knee when doing
No,
that tests? Okay.
no.
And I'll start examining the back. I'll ask the patient to sit on the examination table. I will ask him to examine the back. Is there any tenderness on palpating the back?
No,
Okay. Any tenderness on palpating lower back or
no,
sacroiliac joint? No. Okay. Now we'll be examining also the chest, listening for the heart, particularly the aortic area, if there's any murmur or anything.
no, Momo.
No murmur. And from general examination, is the patient hands, how do they look?
Normal.
Normal, no wasting.
No wasting.
Any tender joint when palpating the joints of the hand?
No,
No. And the wrist?
no,
And asking the patient to lower the eyelid. Is there any pallor?
no pallor.
No pallor, yeah?
No pallor.
And then the mouth, asking him to open the mouth, looking for any abnormality. Is there anything on the
No,
finding?
no, no.
No. Okay. I would perform a quick motor assessment uh, for for the power in the upper and lower limb. Is there any abnormality in the power?
Power. No,
No. And other than this, can I ask the patient, do you have any pins, needles, sensation problems in any of his upper and lower
no,
limbs?
no,
Okay. Any rashes anywhere in the armpit or in the groin, the private parts?
no,
Any rashes in the sole of the foot?
no.
Okay. Now I think we still have time. So thank you, Mr. John, to allowing me examining you. Do you have any concern in your mind
Doctor,
that I would need to address?
what exactly is going on with me?
Well, to be honest, I think might be um,
2 minutes
an
left.
an inflammation that's happening in your joints. Can I ask you? I will, of course, I will tell you what we will be going. We will need to have some investigations to look into that, and we will have a further chat about that. One thing I would like to know from you, do you have any family history of any problem?
Oh, yes. My
Mhm.
father, I don't know if quite important, my father has skin problem. He has psoriasis.
Okay. And you are concerned about anything else apart from what we've discussed?
No, just wondering what's going on.
Mm-hmm.
And yeah, that's just what I'm worried about.
Okay. So I think at the moment it's important that you will have some help reviewing you. We want you to address your place of living, and I think I will refer you to a joint doctors
Okay.
and then also, which is one of the member of the team, and I think we can refer you to a physiotherapist and occupational therapist so they can look into the adjustment that you might need at work or at home, because I believe you need to review you need reviewing those needs. Are you
All right.
happy for me to
Yeah,
do so?
yeah, it's
We
okay, doctor.
in the
But do you
meanwhile,
think this,
I'm
doctor, do you
sorry.
think this is an infection of the joints?
Well, it is one of the possibilities. I have millions of possibilities in my hands, but it could be. But we are doing some imaging for your knee, and if the infection markers in your bloods are high, we might do some tapping from the joint. Would that be okay with you?
Oh, yes, anything to be all right.
Okay,
Okay. The
thank you.
time is up. Examiner question. Dr. Ayura, please.
Okay, doctor, can you present your positive findings?
Today I examined Mr. John, who has a 4-week history of difficulty walking. On questioning, it appears to be due to pain rather than weakness, and he had similar pains in his in multiple joints in the last 4 weeks. Interestingly, he had 2 years history of lower back pain, and also he had some gritting sensation in his eyes for the last 6 months. This gentleman I didn't identify any recent risk factor to provoke such symptoms to appear, and he denied any trauma. I think this is an inflammatory joint disorder, of which I think it is important. The top of my differential could be psoriatic arthritis, given he had a family history of psoriatic arthritis. Could be ankylosing spondylitis. The next in line could be reactive arthritis. Those are from the seronegative. From seropositive, we would test for that, but we will still need to rule out rheumatoid arthritis, and I think the risk of mixed connective tissue disease should be ruled out, but the patient didn't have any skin changes that would be indicative of scleroderma or dermatomyositis.
Okay, thank you. So, why do you think this patient has frothy urine?
To be honest, I'm not quite sure what's the relevance of this, apart from reactive arthritis could explain the involvement of 3 systems: eye, joint, and urinary symptoms. But frothy urine could be indicative of proteinuria. In this case, I would steer my differential to add systemic lupus to test for possible or potential nephropathies.
Okay, thank you. So, how will you investigate this gentleman?
So thanks for asking this question. I usually start by investigating the patient from the bedside. I would doing full sets of observation, lying standing blood pressure, importantly urinary depth, chest X-ray, X-raying the joint, and ECG and X-ray, and ABG if the patient's saturation is affected. Full blood count, inflammation markers, ESR, CRP, Usenes, LFTs, and bone profile, of course, alongside with basic nutritional bloods. I would send the full battery of rheumatoid factor, ANA, anti-RUNB, and those are for specific bloods. Also, if there is signs of infection shown on the imaging, which I would start by X-raying the joint, we can go for aspirating the joint. This is pretty much what I will start doing.
Okay, so let's say this patient has ankylosing spondylitis.
Okay.
Okay, so how will you manage?
So through multidisciplinary approach, first of all, rheumatology involvement, physiotherapy, occupational therapist, and in fact, genetic counseling might be important, given that there's genetic predisposition through HLA-B27. Occupational therapists are important in order to address the patient's needs in work and at home. And usually we will start the patient on non-steroidal, and then we can move to, if it's not responding with specialist approval, we can move toward anti-TNF.
Okay.
Of course, following up, I would follow up for this patient. I would like to have a baseline echo and a baseline chest X-ray, and the regular follow-ups to look for potential complications in the valves and in the lungs, such as aortic regurgitation and apical fibrosis.
Okay. So what are the other associations of ankylosing spondylitis that you're aware of?
Anemia, ankylosing, apical fibrosis, aortic agitation, ankle involvement also as well.
Any,
Achilles tendinitis.
any other one?
I'm not remembering at the moment. I'm sorry.
All right. Thank you so much, doctor. You've done well.
Thank you.
Okay, what do you think the ankle pain, Dr. Omar here?
It could be Achilles tendinitis.
Yes, Dr. Actually, Dr. Ayula is the one reminding you. I think so.
Yeah, I said Achilles
Yes,
tendinitis.
yes.
Have you heard me?
Yes,
Okay,
Yeah,
Achilles
yeah.
tendinitis.
Yeah.
Okay, perfect.
Yeah, I
Okay.
was saying Achilles tendinitis, so I don't know if it was
Yeah.
heard or not.
Yes.
Yeah.
It's nice case. Thank you, Dr. Ayula. Very well done, Dr. Omar also. Let's go to the comment. Dr. Ayula, then I will comment.
Okay. Well done so much. You did so well. History taking, it was a good one. Even the ones that seems you missed, you went back to it as a family history. That was one thing I've noted down that's quite important in this patient. You went to town with the history taking. This is a case of cell negative spondylitis. And you took a
Dr. Ayula, excuse me, sorry to interrupt you. I want you to comment based on the skills one by one.
Okay, all right. So let's talk about the
Yeah.
skill. Physical examination, you examine or everything I noted down for examination, you did, but you didn't excortate for the apex bit, which is quite important in this patient. But you check for anemia, you check for, I think lymph nodes too might be important in this patient as well.
I'm sorry, what
lymph
is
node.
important? Lymph node, yeah.
Yes. But you missed the lymph node. You check for anemia, which is important in this patient. Cardiovascular risk is also important. You check for blood pressure. Those are the things I've noted down. Then I put abdomen examination because this patient is already having fraudiness of urine. So you need to examine the abdomen as well, just to look at if there's any tenderness, any enlarged kidney from the amyloidosis, which is a risk in this gentleman. Okay. Then the identify sign, the sign you identify, you were able to identify the signs that I calibrated for this patient. You look out for AR, though absent, but you were seen looking out for it. You look out for anemia, which you were able to pick. Then you examine the ankle so well. You check for tenderness, you check for temperature change, you check for skin changes and the movement as well. And you check the patient's gait, which was antalgic gait, which was good. Communication was also good. Clinical judgment was good because you were able to look out for risk factors. I mean, to look out for important investigations in this patient. And you mentioned the HLA-B27 during your discussion. Your judgment was also good. Differential diagnosis was top-notch for this patient. You addressed my concern, and the welfare was also good. For this, I think you did so well in this. From my own perspective, I think you did well, and your history taking was good as well.
What
The
thing
management.
I'm sorry, what thing you can feel that I could have done better? This is
Okay.
toward the end of your comment.
Yes, what I think you could have done better in this patient, your history in terms of the leg, the examination of the history taking of the legs, you were not initially, though you went back to it, but initially you didn't take a full detailed history of the leg pain. How did they start? And just asking for things that make it worse. So though you went back to it, but you could have forgotten if under exam pressure. It's always good to bring them forward immediately. Just do the Socrates of the pain first before you start looking out for every other association. You look out for every other association before you went back to the pain. So the Socrates first will have been good in this patient. That's one thing I noted down. Then the family history is always good to bring it early because it will help you in this patient is quite important, though it's not a psoriatic arthritis, but it could be a possibility. If you think about that early, it will have helped you. Then one thing I also noticed that you missed in this patient is you didn't check for the nails, for pitting nails. If you are thinking of negative spondylitis, you should check for nail changes. in this patient, which you means. But I think if you are doing it physically, you will have looked at it more closely, possibly because it's an online discussion. That make it a bit difficult. Then I think that's just things that I've noted in my history wise, and the examination too was good. I think you did so well in this case. Thank you. And the differentials was good. Management too was good. The NSAID thing, the tumor necrosis factor, but because this patient has peripheral joints involvement, the patient also benefit from the DMARD. But if it is just the HCR spondyloarthritis, it doesn't need a DMARD. But because it also had peripheral joint affectation, you can also bring in the idea of DMARD.
DMARD is preserved to the ankylosing spondylitis with arthritis. So yeah, you are right. Thanks thanks very much for reminding me about that.
Yeah.
Okay, thank you, Dr.
You can bring it
Aymana.
in. Yeah.
Yeah, nice case with good coverage. Okay,
Thank you. Well
continue.
done.
Sorry,
Thank
sorry,
you,
sorry,
Hala.
sorry. You want to add anything?
No.
Okay, you're done?
Yes, I'm done. Thank you.
Yeah, okay. I want to start the comment from the word of I have million of possibilities. Dr. Omar, please don't do it in the exam. The
Okay.
examiner will tell me the million possibility you are talking about. Till here, I have many possibility. Don't count for here. Okay? So he will think that you are overconfident. You have million of possibility. Oh my God! Even the medicine doesn't have all this million the possibility. Anyway, don't mention numbers as a talk or as an answer. This is the first comment. Otherwise, the whole performance was perfect. Really, the family history you mentioned at the end remind you about this, but please remember it earlier. One more comment regarding the differential. It's seronegative arthritis. And to be sure that you can ask about the stiffness, which he didn't touch any stiffness in the joint. He will tell, or she will tell, yes, I have. For how long? To have rheumatoid, you can say for more than 1 hour, it's rheumatoid arthritis. If less, you can suspect seronegative arthritis. One also possibility here, it's very important to put in your differential, the psoriatic arthritis. She told you, or the surrogate told you that my father was having psoriatic arthritis or psoriasis, right? It's still one of the familiar conditions. Yeah,
which I
genetic.
thought, I think.
You said psoriatic?
Yeah,
I heard only seronegative as reactive and ankylosing.
And psoriatic. I
You mentioned
three.
psoriatic?
Yeah,
Okay,
yeah,
so
yeah.
perfect. Okay, but the seropositive, it's difficult to mention here. Okay, the tendon or Achilles tendonitis you didn't mention earlier, but you remember at the end maybe. The ankylosing as well was the correct diagnosis you have to mention to the patient. The examination, I will ask you now if you remember the 7 A's, and you have to examine one by one for them if you have time, of course, after examining the ankle and the back. What do you think?
The apical fibrosis,
Perfect.
aortic regurgitation. Of course, we will check the pulse and the ECG for the the AV block. Anemia. I've checked the conjunctiva, and the Achilles tendonitis, of course.
Amyloidosis.
Amyloidosis, yeah, toward the end. If it's chronic, yeah.
Okay, you mentioned the AV block, right? Aortic regurg, amyloidosis, apical fibrosis, and yes, anterior uveitis.
Achilles,
Anterior
anterior
uveitis,
yeah.
which he had read earlier. He told you that I have it. Of course, to do the examination of ankylosing, I think you missed the all confirmatory test or examination steps of ankylosing. What do you think they are?
The Schober's test.
Exactly. This is one of them. What else?
The axial movements toward the
Exactly.
side and front and neck movement.
All sides, yes, all sides. Here also, in some cases, they are saying you can you can ask about driving, since the patient might have neck limitation of the movement because of the disease of ankylosing spondylitis. Uh, Other than this, yes, I have mentioned the 7 A's, so you can go through them step by step. Some examiner they can accept and they can give you good marks in the physical examination and identify, but I think they might minus you in the modified Schober at least to offer it, along with the movement of the neck and the
Yes.
back. It's very important to do.
Which can be easily assessed when you assess the gait. You can ask the patient,
Exactly.
yes, it's standing. Yes, you are right completely. Yeah.
Perfect. Yeah. While he stand, please can you occiput to wall test as well, one of the confirmatory. So you can ask him to stand to the wall, and the other one, ask him to bend forward and backward and laterally in all direction along with the neck movement while standing. So you will be more organized to examine while he's standing, gait. Then you can ask him to sit and examine the other parts like Achilles tendonitis or the ankle itself, the movement, the tenderness, the redness, the hotness. It's inflammation, so it could be there. Along with the knee examination because there is history of knee pain. And I think yes, this is my comment. What are what is the most important step of management as non-pharmacological?
Exercise, guided exercise
What we call
programs.
it? Yeah,
Um, if it does have an exact name, it's not on top of my head at the moment, Dr.
it's
Bassem. Let me just check.
hydrotherapy. Hydrotherapy.
Hydrotherapy. Okay.
Yes. So the patient can do swimming. It helps. As you said, as you mentioned, two non-steroidal anti-inflammatory. If not responding, you can start him on medication that could help, like biological
DMARD.
therapy,
Yeah,
DMARS,
but
and the
it's
biological therapy.
it's wise to start this patient as on DMARD since he have multiple joints involved.
Yeah, peripherally,
Yeah.
particularly. But the most important to mention, as you said, TNF and the biological therapy, adalimumab and etanercept. Okay, these are the most important biological therapy you have to mention in this scenario, along with the non-pharmacological, as you mentioned, the occupational therapists. Yeah, there is comment also about the. I agree. You can ask about how you can help or cope with daily activities, climbing the stairs, but the smoking, I think you didn't comment on, or you didn't advise regarding the smoking.
No.
Yeah, so it's important whenever the patient is smoker to address it immediately. If you are thinking
And
about cessation, we can refer you to smoke cessation clinic.
and if you didn't remember, you can reflect on that on the multidisciplinary team on the management question. At
Yes,
least you
if you
will touch some mark. Yeah.
exactly. If
Yeah.
you forget while taking history, do it while talking to the examiner.
Yeah. Yeah.
Okay. Otherwise, perfect, Dr. Omar. It's a nice case. But really, it was, or both cases were very impressive today. The TB and ankylosing. And by the way, both of them are very common in UK and or for overseas. So it's one of the nice session, informative one, a good discussion, and the performance as well. Any question, Dr. Omar, or comments?
No. But yes, the take-home messages
Yes.
is the Schober test. But to be honest, when I was examining the patient, I was thinking of 2 or 3 differentials. In the very beginning, I was thinking we are dealing with weakness, and then when it is pain, then I started to, as we discussed in 2 days ago about the mechanical and the
Exactly.
the
Yes. Is it
inflammatory
perfect?
pain.
So you learn from the last lesson, which is inflammatory or mechanical. You applied it here, which is
Yeah.
perfect. That's why you know this is a case of inflammatory back pain. I wanted also to comment that the take-home message for you, whenever you have a case like this and you face it in the exam, believe me, you will be lucky. So you will thank Dr. Ayula maybe after a couple of days because you will do
Yeah.
all the steps appropriately.
Yeah.
So try to revise the topic today from A to Z quickly. It might be there in your exam after a couple of days.
I
Okay.
hope so.
Yeah.
So
Yes. By the way,
any advice
ankylosing
for
is
the
very common.
Schober? For the Schober's test, if because you have many systems to go after, and I think the history usually in this
Okay.
is a bit of an advice. So a history usually in inflammatory disease tend to take some, at least it will touch the 8 minute limit,
Yeah, exactly.
because there are so many associations you need to rule out. So if you felt yourself short in time, what is the best strategy?
The golden advice, if I would like to do all of them and I don't have the time, do the complaint first. Do
Okay.
one of the confirmatory tests, at least the occiput wall. It's very easy one. Then I will offer the modified Schubert. Why? Because it's little bit taking time, and the patient will stand, and you will mark on his back. So it will take time, and maybe also it's something need to be offered, and a permission from the examiner and permission from the patient. So do the others, then at the time of examining for modified, ask him, can I go for a modified Schubert test? Either he will tell you yes, go ahead, just to know if you know it or just you are saying it. Okay,
Mhm.
maybe he will tell you no need, skip. Maybe he will tell you, okay, show us how to do. Then from the first step, if you do the mark up and down, he will know that you know that how to do it. Then he can tell you, okay, what else you want to examine. Okay, the other things, 7 is you can do it in the systematic way. So you're starting from the hand, the pulse, the joint in the hand, quickly, because you cannot cover all of them. The eye for the redness, anterior uveitis. Then
Listen.
yes,
Okay. Yeah.
listen to the back, apical bilaterally. Listen to the heart, aortic area particularly. Don't go to the all heart
Yeah.
valves.
Aorta. Yeah. Aorta.
Aortic, yes, aortic gauge and sitting position. And the amyloidosis for the kidney pollutment. That's
Mhm.
it. Of course, after doing the ankle examination, I said initially the examination of the ankle is the essential one in this case. Okay.
Yeah. So, but
Perfect.
I did the ankle examination,
Yes,
or
perfect. You did it.
yeah.
Yeah, yeah. I believe you did it. You do it perfect.
Is there anything that I missed in the ankle examination or might not be aware of?
Yes.
Um,
So examine any joint. Look and
yeah.
feel. Look, feel, and move. Look, feel, and move. So
Okay.
you are looking on at both ankles. Okay.
Yeah.
To compare, is there swelling here and there, or there is asymmetry, or there is deformity? Anything you can notice by your eyes. Then the feel for the hotness. Okay, and compare, of course, both legs together, and at the level of the ankle and above and below, just to, by your dorsum of the hand. Okay,
Yeah.
so you are doing compare in the hotness or warmness. Then, of course, the redness, one of the thing you can see by your eyes. Okay, asymmetry and the swelling and the redness. Now the time of move. There is two movement you have to do: passive and active. The passive you ask, you will do by yourself. Passive, you will ask the patient to
To
relax
relax.
and try to move after permission. If there is any pain, please let me know. If he said yes, I have pain, tell him I will try to be more gentle, or the examiner will tell you no need, or try to do it gently. This
Mm-hmm.
is the passive one. The active one, ask the patient to move all over and in all direction, up and down, right and left, lateral and medial, and both ankles, of course, but more focused on the affected one. That's it. This
Ooh.
is for any joint examination: look, feel, and move. Okay. The gate, of
Okay.
course, you can offer it at the end, along with the other modified sugar and the occiput wall tests.
Okay. One question, it might not be related to the today's case.
No problem.
In the approach of tremors,
Yeah.
uh, when you do the examination, if it's, for example, you've noted that you are approaching essential tremor, or um, it's difficult to do the full modality of neurological examination. You, of course, you will start assessing the gait, doing the Romberg, and then examining the upper limb and lower limb. But I was thinking of let's do the examinations of the Parkinson's, and
Exactly.
then
Yes.
you can verbalize, or you can at least touch with the motor and of upper and lower limb, like power at least. Would you advise me to do
It's
so?
it's hand examination first of all. So
Yeah.
Parkinson, to say mostly in the exam, tremors means Parkinson disease. So you have to start from the hand, bell rolling, the bradykinesia, the rigidity. You have to
Mhm.
recognize all of them to show the examiner that I am looking for Parkinson. Or to roll out the other tremors like essential, it will be kinetic tremor while the patient is moving or what's is not while moving or while resting. You have to know what the type of tremor, of course, in the history. But if you, in terms of Parkinson, you have to specify the examination of the Parkinson, the rigidity, bradykinesia, and tremors.
And then to ask the patient to draw a circle and to write a sentence.
Yes. So you have to, if you are suspecting Parkinson, you have to roll out the Parkinson plus, as you mentioned.
Yeah, the gaze, and by asking for urinary symptom, erectile
Exactly.
dysfunction and stuff.
This is in the history, but I'm talking about examination.
Uh,
So we'll go through the examination steps: power, tone, power, reflexes, sensation, quickly. One deep, one superficial.
mhm,
Don't go all the details of the sensation.
mhm.
Then for the eye, you have to do for the supranuclear palsy, the H shape, and you offer blood pressure examination for posture hypotension, for multi-system atrophy. And in the history, of course, you can roll out the hallucination for
Mhm.
Lewy body dementia, and the other questions for
We can
impotence.
examine, yeah, we can
Yeah.
examine the eye, the gaze movement for the PSP, and
Yes, I
the
said H
Cassini.
shape.
Oh, yeah, 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 it's
H
shape,
shape.
yeah,
Yes,
yeah.
H shape. Okay, but don't forget the three triad of
BTR,
Parkinson's.
the bradykinesia tremor.
Bradykinesia, you know how to do the bradykinesia,
Yeah, yeah, yeah,
right?
and the synkinesis
And the
also
sykinesia,
afterwards.
one of
Yeah.
pathognomonic tests. This is related to the Parkinson. If there is possibility of thyroid, you have to examine the thyroid. Okay, it's because
Okay.
thyroid also can cause tremors. There
Yeah.
is also tremors for cerebellar syndrome, so you have to do cerebellar syndrome or cerebellar manifestation examination in term of Danish.
Yeah.
Okay, so it depends on the case, or it will be short case. You have to do the most.
One modality. Yeah.
Yeah, one. I think Parkinson. It would be there, particularly the rigidity. You will notice the rigidity properly. There is a lead pipe in the elbow level, and cogwheel at the
Could
wrist
we have
level.
the rest?
Okay. Yes. Anything else you want to ask?
No, no,
Okay. Okay. Thank you, Dr. Amar. Well done.
thank you.
You have another station, right? Or this is the last?
I don't know if there is any possibility tomorrow. I don't
Okay.
know.
Try to
If
be
yeah,
attending in case of anyone has apology,
yeah,
so you can attend. You can practice as well. But as you see, the schedule is very congested.
yeah, yeah, yeah.
Okay. Hopefully you will do perfect, Dr. Omar. We'll
Thank you.
pray for you. It will be the Saturday, right?
Friday, inshallah,
Friday. Oh, okay. You have just 4 days.
inshallah.
Okay. Best of luck, Dr. Omar, and message me whenever you need anything.
Thank you.
And in case, again, anyone apologize tomorrow, you can do as
Yeah, yeah,
planned.
of course, yeah, inshallah,
Okay.
inshallah.
Okay. Thank you, Dr. Omar. Anyone want to add any comment before moving to the comments chat box?
Yes, I can I add some
Yeah,
comment?
yeah.
Yeah,
Okay.
okay. I think that there are few things I just want to, because Dr. Umar is about to go into the exam very soon. So the first thing is regarding the history. I think that you need to tick the boxes. So I think here you didn't ask about the past history. You asked the family history very late when you were addressing the concerns. So please make sure that you at least tick the boxes because they carry marks. So because might not, family history obviously was relevant, but I think that uh, even if it is not relevant, so you just need to take box the past history and the family history, the medication history, and all these things, because they just look into the scheme and they just do marking according to that. One thing is, the other thing I feel that regarding your history taking, I mean, it's a problem with me, so I understand it is something which that you were a little bit slow in taking the history, and you were, I mean, kind of a going very slow. So in the exam, and you started examination from 9 or 9.5 minutes. So you just need to try and speed up a little bit more, because I think generally it's recommended that you need to start the examination maximum by 7 to 8 minutes. So if you are staying with the patient for 9.5 minutes just to dig in the history, I think that you might not be getting enough time to examine the relevant. The thing relevant is that, for example, in this patient, if you are able to just examine the relevant system, and if you didn't get time to examine, for example, the heart or the lungs, and to look for any extra articular manifestation or the association, you can mention at the end to the examiner while finishing that I would like to complete my examination by examination of the eyes, the examination of the lungs to look for apical fibrosis, examination of the heart. So you can mention, obviously you can offer these things even you have, but the important thing is that you need to make sure that you do the relevant at least. I think at 1 or 2 point I felt that you were a little bit dismissive of the complaints of the patient. She mentioned to you that she has backache for the last 2 years. You didn't analyze it properly. Whenever you get a backache, you need to analyze whether, as we discussed a few days ago, that what kind of pain is it. So just need to make a mark that whether it is an inflammatory, because very important in this patient, because you need to analyze, because if you find an inflammatory back pain and now pain in the ankle, so whether it was an ankle joint or Achilles tendon, but now you have a direction that which way it is going. So it is always, I mean, if someone is saying a symptom, because in the exam generally they will guide the patient to the surrogate to say yes only to the symptoms which are important. So if someone is telling you that I have a back pain, I think that you need to analyze that, and the same way in 2 or 3 questions like stiffness, early morning stiffness or gelling, at what time the patient feeling that the pain is worse. So just to analyze whether it is mechanical or is it inflammatory. Once you start with the inflammatory, now you have a patient, suppose within the first 2 3 minutes you have analyzed, okay, this is a patient who has an inflammatory back pain and now having a pain in the ankle. Now, your thought process should be on the differential diagnosis of an inflammatory back pain. And generally, from an exam point of view, it is just four major things. We are thinking about a seronegative arthropathy, seronegative spondyloarthropathies. So, just need to tick the boxes again. So, skin rash. So, you just looking for psoriasis, ask about any skin rash. No skin rash. Okay, go to GI symptoms. Have you got any lose motion or lose stools? No. Have you ever noticed blood in your stool? No. So you're just ticking the boxes, and the examiner know that now you are going smoothly into differential. Now the third thing, it could, young male, young female could be reactive. So ask these sensitive question. Ask about any discharge from the urine, any redness in the eyes. So these are the things which will help you in guiding which way it is going. If you didn't find anything, now you're most likely thinking in terms of an ankylosing spondylitis. So now take it in detail. I would advise you, when the patient or someone is saying that I have pain, because she mentioned very early on in the history that I have been feeling pain in the ankle. I think it would have been more appropriate that if you can just ask her, can I have a look at the area where you're feeling the pain? Because if it is a painful and a swollen area right from the start, you will be able to pick up the pain is not in the joint, it is more on the back of the, and no, right by looking at it, you will feel that, and you see that the Achilles tendon is swollen. So I think that that would guide you further. Okay, there is a patient with Achilles tendonitis, and I mean, I just wanted to tell you that these are the clues which will guide you further which way it is going. Trauma history in backache, you should always ask just to make sure that you're not dealing with a traumatic pain. Lastly, again important, whenever you come across a patient with back pain, whether it is inflammatory or a mechanical back pain, always look for red flag signs. Have you got any pain in your legs? Have you got any weakness in your leg? Any numbness or tingling in your legs? Have you ever lost control of your bowels? Have you ever lost control of your waterworks? So I think that these are the things which will help you. As I said that you might not be able to take all the details, but these are important details which should not be missed. And when you are doing the systemic and you have a background history which goes more in favor of a seronegative, so as she has already mentioned, the redness of the eyes and recurrent redness in the eyes. So you can think about a possible uveitis here. So look for other symptoms, any cough, any chest pain, any breathing. So even if you have asked and screened these questions and patient says no, when you are examining the patient and you did not get time to do a cardiac auscultation or auscultation of the lung, you can offer it at the end because you can say to the examiner that the patient did not mention any cough or any complaints. So, but I would still like to examine and offer this examination to rule out these possibilities. So it's about time management and how effectively you deal with your time. So I think
Okay.
these are the
Yes.
few things I just wanted to make a comment on because I think that the backache history in my point of view, you ignored that and you didn't analyze which was important because Achilles tendonitis could be due to other reasons. So unless and until you analyze that back pain, I think it would be difficult for you to exactly tell that what exactly is going on. So these are few things because you have an exam. So I thought that this might be helpful.
Okay, thank you, Dr. Hacham. Very nice. I will add also to your comment the scale of the pain. Never ever forget it because you missed here also the scale of the pain. And whenever the patient is having eye or vision issue, you have to ask and address the driving. Don't forget this, Dr. Omar. Okay. Quickly, the chat box I will go through. Yes, occipit wall. Yes, exactly. Atlantoaxial subluxation. It happened with rheumatoid arthritis. AV block we mentioned. Achilles tendonitis, anterior amyloidosis, aortic regurg. Exactly. Yeah, Dr. Amal wrote the correct diagnosis. And sorry for deleting the comment, Dr. Amal, because it was the correct. And I wanted Dr. Omar to know it by himself. Thank you, Dr. Omar and Dr. Ayola, for the participation today. Thank you, everyone, for the
Dr.
comments.
Bhaskar, what was the reason of frothy urine? Is it due to
Amyloidosis.
amyloidosis
Amyloidosis. Yeah,
or was
amyloidosis.
that due to the use of
Both of them.
anti-inflammatory?
It's two reasons are there, either amyloidosis or IgA, analgesic nephropathy because of
Yeah, yeah,
non-steroidal. So please don't forget both of them as a
yeah.
possible cause of. Sometimes also it comes as renal failure because of multiple use of the non-steroidal. Okay. Okay. Thank you, everyone. See you tomorrow, inshallah, the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.